That debilitating back pain can feel like a life sentence. And we all do it, right? We immediately jump to conclusions. Maybe it's a slip disc or sciatica or just plain old arthritis. But what if the cause was something else? Something hiding in plain sight on a routine MRI? Well, today we're going to explore a condition that does exactly that.
So, no, this isn't about worn-out discs or inflamed joints. We're talking about something that looks a lot like those common problems, but it comes from a totally different source. So the real question is, what's actually putting the squeeze on your nerves?
And here is our culprit. This right here is spinal epidural lipomatosis, or SEL for short. What you're looking at in these MRI scans is a crazy amount of otherwise normal fat tissue. See those bright white areas? It's just building up in the spinal canal, and it's literally squeezing the life out of the space meant for the spinal cord and nerves.
All right, so let's formally introduce this thing. Even though it's considered rare, spinal epidural lipomatosis is a known cause of nerve compression. The problem is, its symptoms can be super easily mistaken for more familiar back problems, which makes it a really tricky diagnosis.
So for the patient, this can mean anything from just a chronic lower back pain to that sharp shooting pain that goes right down the leg, what doctors call radiculopathy. And in more serious cases, it can even cause weakness or neurological emergency. But at the end of the day, it's all about one thing: pressure.
Okay, so let's get a little more specific on what is actually happening inside the spine. It's important to know this isn't a tumor or anything like that. It's just an overgrowth of the body's own tissue in a place where, let's face it, space is at an absolute premium.
Here's a good way to think about it. Imagine your spinal canal is a rigid tube, and your nerves are the delicate wires running through it. Normally, there's some epidural fat in there that acts like packing foam, right? It's a nice little cushion. But with SEL, it's like someone just keeps shoving more and more packing foam into that tube until the wires get totally crushed. The fancy medical term is a diffuse hypertrophy of unencapsulated adipose tissue, which really just means a massive overgrowth of fat where it has no business being.
And this is a fantastic illustration of how SAL is diagnosed and graded. So when a radiologist looks at an MRI, they're measuring the ratio of that epidural fat to the dural sac, which is the space that holds the nerves. And you can see it right here. The more that fat builds up, the more it squishes that sac. It goes from a nice, healthy, round shape to a compressed kind of Y shape in the really severe cases.
Okay, so the big question is, what triggers this overgrowth? For a condition that's supposedly uncommon, its causes are surprisingly tied to some very common health factors and medical treatments. So let's break down the 5 main culprits.
So a big literature review back in 2018 pointed to these 5 main causes. First up, we have exogenous steroid use. That's just a way of saying long-term use of medications like prednisone. Then there's endogenous, which is when the body itself goes haywire and overproduces steroids, like in Cushing's syndrome. After that, you've got obesity, some pretty rare cases caused by surgery, and finally, my favorite, idiopathic, which is just a medical way of saying we honestly have no idea what caused it.
And this chart, wow, it really tells the story, doesn't it? The 2 biggest drivers are just crystal clear. More than half of all cases are linked to long-term steroid use, the kind of medication prescribed for all sorts of other conditions. Then nearly a quarter are tied to obesity. So you add those 2 up, and bam, that's about 80% of all SCEL diagnoses right there.
Okay, so we know what it is, and we know what causes it. But who actually gets it? Well, a really interesting study out of Korea by a researcher named Park and his colleagues gives us a fantastic snapshot of the typical patient.
So what they did was look at a bunch of patients who were already getting an MRI for back or leg pain, and they found that 1.1% of them had this condition. Now, to put that in perspective, think about it like this. For every 100 people in that group, people who already had symptoms, about 1 of them had SEL as a possible reason for their pain.
And get this, the average age of diagnosis was almost 70 years old. That really suggests that SEL is a condition that tends to pop up later in life, which makes sense, right? It likely happens after years and years of exposure to those risk factors we talked about, like a high BMI or being on steroid meds.
This table gives us a really clear snapshot. So the number 1 complaint, that classic combo of lower back pain and pain shooting down the leg. And what else is common? High blood pressure or hypertension, which seems to go hand in hand with it. The problem area is almost always at the very bottom of the spine, at the L5-S1 level. And here's something really interesting. The study found that men were more than twice as likely to get this diagnosis as women.
All right, so this leads us to the most important question, right?
What can we do about it? Well, the good news is, once it's diagnosed, there are some pretty clear paths for treatment. They basically fall into two main camps: conservative and surgical.
Now, these two strategies have very different goals. The conservative route tries to shrink the fat by tackling the root cause, so that means losing weight if obesity is the problem, or working with your doctor to carefully reduce steroids if that's even possible. Surgery, on the other hand, is more of a direct mechanical fix. A surgeon goes in, performs what's called a laminectomy. That's where they remove a little piece of the vertebra to make more room, and then they physically go in and remove or debulk that excess fatty tissue. But, the decision to operate is a really big deal. It's not something they jump to. Surgery is generally the last resort. It's reserved for patients who have severe or rapidly worsening neurological symptoms, or for people who've already tried the conservative approach and just haven't gotten any relief.
And this is exactly why that caution is so important. This quote really hits on a critical point. Look, the surgery itself is usually effective at relieving the pressure. But the problem is, the patients themselves often have other major health problems. I mean, the very same issues that are linked to causing SEL in the first place. And it's these underlying health conditions that make the recovery and the whole period after the surgery so risky.
And that leaves us with one final and I think really important thought. We call SEL a rare disease, right? But its main drivers, obesity and the widespread long-term use of steroid medications, are anything but rare. In fact, they're becoming more and more common every day. So the real question we're left with is this: are we on the verge of seeing this hidden cause of back pain step out of the shadows and become a much more frequent reality?